we'll start our first talk by Dr. Iyas Al-Musa. He's a well-known consultant cardiologist, a fellow of American College of Cardiology, and he's mainly based at Al-Istishari Hospital. And he will talk to us this afternoon about triglyceride-rich lipoproteins, the new frontier in atherosclerosis. So the floor is yours, Dr. Iyas.
شكرا دكتور، ومساء الخير للجميع. مساء الخير بعد 12 طبعا. بشكركم على الدعوة، بشكر دكتور محمود على اختيار الموضوع هذا. بصراحة لما حكى لي ترايجليسرايد ريتش لايبوبروتين لقيت انه ممكن تكون هاي محاضرة مملة عن الفسيولوجي اوف لايبوبروتينز وايبو اي والليبيدز وكل محاضرة اللي كلنا كرهناها بالميديكال سكول. فانا قررت اعملها كلينيكالي ريليفنت على شو في شيء مفيد بالعيادة على الترايجليسرايد بدنا نعرفه. وهي يعني كول فور اكشن. لما نحكي على الليبيد لورينج في عندك انتنسيف ابروتش، كلنا حكينا دائما push the statins to the highest، استعمل high dose statin، intensive statin therapy، the lowest is best. بس سؤال، هل هو ال LDL treatment لا زالت هي البريوريتي تبعتنا to prevent cardiovascular events؟ والجواب هو نعم قبل ما نحكي شيء. يعني LDL هو التارجت الرئيسي تبعنا، بس هل LDL كنترول كافي؟ والسؤال الثاني، الكونفنشنال تريتمنت او الانتنسيف تريتمنت مين يعني بروز اند كونز، وشو ممكن نعمل؟ احنا بدنا شغلات تفيدنا بالكلينيك بكره بس نداوم نعرف شو نعمل بمرضانا. هذا راح احاول الخصه بال 15 minutes الجايه. هل LDL كنترول لا زالت توب بريورتي ان بريفنتينج كارديوفاسكولار ايفنت؟ الجواب بالسلايدز اللي قدامكم. هذا الكيرف بفرجيك الايفنتس فيرسس LDL. كل ما تنزل LDL بينزلوا الايفنتس بكل وضوح. والهوب كان اذا بتشوف الكيرف اثنين بلشين على الزيرو او بوصلوا للزيرو، كنا نامل انه if you drop the LDL low enough you will find an event rate of zero. وات one point كنا نحكي للناس اذا ال LDL بنزل below 30 you will have a cardiovascular event of zero. وهذا صار مش مزبوط، did not happen، لانه اولا it's very difficult to get LDL below 30، بس برضه الاكسترابوليشن هذا كان مبالغ فيه او متفائل فيه اكثر من اللزوم. even if you drop the LDL تبعك ل 5 your event will continue to be there. وهذا واضح جدا من اللي already الصبح حكوا عنه على residual risk. بس برضو انه you have to have another factor. هو مش معقول LDL هو يعني المجرم الوحيد بالموضوع. LDL control is not enough. اذا طلعت على الميجر ستاتين ترايلز هنا، افترض الخط الفوقاني 100% هو الكارديوفاسكولار ايفنت بالبلاسيبو. اذا شفنا البلاسيبو اعتبرناهم 100%، طبعا مش 100% هم، بس بنجيب البلاسيبو بنقول هدول صار معهم مثلا هالقد ايفنتس. قديش نزلنا؟ قديش الايفنتس بالاكتيف تريتمنت؟ اذا افترضنا البلاسيبو 100%، بتطلع الارقام 70s 60s، حتى بون ستدي دايابيتكس 90، يعني انت نزلت الريسك من ثيوريتيكالي 100 ل 70 60. من ضل عندك كل هاي البارز، كل هاي العمرات اللي واقفه هي ريسك موجود. فانت ما يعني صح فت المريض ونزلت you saved lives و events، بس مش يعني مش لدرجه اللي بدك اياها. بالغنا في تقدير يعني قديش اللي عملناه. ونفس الشيء بنطبق على الريجريشن. لما تعطي اجريسيف ليبيد لورين ثيرابي اوكي بنزل الكيرف تحت ال100 بس بضل 80%. فالمرضى ذي ستيل هيك المرضى بكون ماشي على دواء، بيجي ما عنده MI، بيجي عنده ستروك، بقول لك يا دكتور رغم الدواء صار معي. الجواب بالسلايد اللي قدامك هون. ف optimal LDL is not enough، حتى لو نزلته قد ما تقدر، قد ما المريض يتحمل. هلا الريزيدوال ريسك مهم جدا، وواحدة من الشغلات اللي الريزيدوال ريسك بينت فيها بدراسات البروفيت الايديال والتي ان تي، هدول المرضى اخذوا ستاندرد ستاتين او انتنسيف ستاتين. لاحظ انه حتى اللي اخذ انتنسيف ستاتين نزل مثلا من 26 ل 22 مثلا بالبروفيت، فالارقام نزلت ب 1 2 3% ابسولوت ريسك ريدكشن، بس ما كانتش فظيعه. يعني صح statistically significant واخذت ابروفال وصار الجايد لاينز push to the max، بس الارقام لا زالت متواضعه. هلا واحده من الشغلات اللي بتخلي الريسك موجود هم اللو HDL والهاي ترايجليسرايد. هذا المزيج من ما يسمى اثيروجينيك ديسليبيديميا، يعني مريض عنده LDL زبط له اياه بس ضل عنده HDL واطي والترايجليسرايدز عاليه. هذا المزيج مأساة. هون اطلع حتى الناس اللي عندهم LDL below 70، those who achieved LDL below 70 they continued to have residual risk اذا ال HDL بعده واطي والترايجليسرايدز بعدهم عاليه. وتشون على الليفت بالكيرف بالبار اللي على شمالك، which clearly shows حتى انت مبسوط ال LDL تبع مريض تحت ال 70 ولكن لا زال عندهم ايفنت. طلع على ال HDL كوانتايز، لما تقسم ال HDL those who have an HDL that is normal have lower risk على يمين السلايد، و those who have an HDL that's low have higher risk. فنزلوا كلهم تحت ال 70، بس اللي ضل عندهم HDL تحت الواحد they have more risk. اللي HDL تبعهم اعلى او normal above 55 ملغ كانوا in a better shape. فاستمرار المريض بلو HDL رغم نزول ال LDL below 70 increase their risk. نفس الشيء بنطبق على الترايجليسرايد. بالبروفت برضو الناس اللي الترايجليسرايد تبعهم ظلوا عاليين they have more risk. ممكن تحكي رقم سهل، إذا أنت نزل ال LDL تبعك تحت 70 بس your triglycerides are still above مثلا 200 you have significant risk. معناها فينا two new targets. بدنا نرفع ال HDL which is almost impossible وننزل triglycerides which is more possible. الاكورد ستدي اطلعوا على شيء زي هيك، قالوا طيب خلينا نطلع على المرضى اللي عندهم هاي ترايجليسرايدز لو HDL ونشوف اللي عندهم اثيروجينيك ديسليبيديميا. بهاي الدراسه كانت defined as HDL below 34، خلينا نعتبرها 35 for simplicity، وترايجليسرايد above 204، خلينا نحكي 200. HDL below 35 triglyceride above 200 هدول عندهم 70% relative risk of major cardiovascular event، اللي بضل عندهم هيك. فاحنا اللي ما عنده هذا الحكي his event to the left of the screen، اللي عنده على اليمين of the screen. فهدول تو بريدكتورز سهلين جدا يحكوا لك انه مريضك رغم انك نزلت ال LDL تبعه الافرج LDL was 80 بهاي الدراسه they continue to have this problem. ليش؟ الثلاثي القاتل على يمين الصوره low HDL high triglyceride small dense LDL. ليش؟ low HDL high triglyceride بخلوا ال LDL يصير صغير ودنس مور اوكسيدايزبل مور اثيروجينيك. فالمريض قد يكون عنده LDL 80 ليفل بس هدول 80 ملغ من الاشرار اذا عنده لو HDL وهاي ترايجليسرايدز باد اكسترا باد LDL، لانه اذا كان سمول دنس حتى ال LDL في سب جروبز باد اجلي ماشي حاله. فاذا كان ال LDL سمول ودنس اتس مور اثيروجينيك. for the same value of LDL you can have more damage and more toxicity. فالاكورد اطلعوا على طيب خلينا نطلع على which agent can we use، niacin fibrates omega 3. الفينوفايبريتس هم the usual هلا treatment for triglycerides. في omega 3 debatable، النياسين تقريبا انقرض من العالم. فالدراسة طلعت على اوكي let's look at patients who have this problem ونوزعهم مع سيمفاستاتين مع فينوفايبريت او سيمفاستاتين لحاله ونشوف الeffect of this combination therapy versus السنجل ستاتين ثيرابي. والدراسه كانت very well equipped وكانت ممتازه وطلعت very significant، هاي شفتها سلايد اوريدي، انه الناس اللي you succeeded in combining السنفا مع الفينوفايبريت versus الناس اللي اخذوا بس سنفا طلع على اليمين significant reduction بالاثيروجينيك ديسليبيديميا، وبالتالي event rate were reduced. بمعنى اخر انك انت لما تضيف السنفا مع الفينوفايبريت for the same level of LDL you have a significant impact على الايفنتس. وهذا كان طبعا شيء مهم جدا. طبعا تحكي هذا الحكي اهميته برضه بالدايابيتكس اكثر من النون دايابيتكس. الميجر كارديوفاسكولار ايفنتس were reduced وهلا حنحكي على تفصيلهم. اذا طلعت على ال tolerability ما كانش في زياده. في كثير ناس بخافوا انه تضيف ستاتين على فينوفايبريت they were get rhabdomyolysis ومايلجياز، ما كان في significant difference. البي فاليو على اليمين was not different. ف this was very well tolerated adding الفينوفايبريت للسيمفاستاتين. ليش الحكي هذا؟ الريزيدوال ريسك بالدايابيتكس مش بس one thing، عم تحكي على ريتينوباثي، عم تحكي على نيوروباثي، عم تحكي على نفروباثي اللي هو مايكروفاسكولار، وعم تحكي على ماكروفاسكولار اللي هو الستروكس والام اي. فهذا كله ريزيدوال ريسك والمرضى they continue to have these events. فالاكورد كانت هيك. هلا الفيلد ستدي نطلع على شيء ثاني، فينوفايبريت بلارجر نمبر اوف بيشنتس، دايابيتك بيشنتس نفس الفكره، بس تقريبا اول كمرز كوليسترول اتش دي ار ريشيو عاليه او اي ترايجليسرايد ليفل من ترايجليسرايد 100 او 88 هون ل 500، يعني اي ترايجليسرايد بواحد دايابيتك. خلينا نجرب نعطي ايرلي كومبينيشن لفينوفايبريت مع ستاتينز. وهي الدراسه على فكره should be a practice changer. اذا طلعت هون الترايجليسرايد بيز لاين بالدراسه كان 171 تقريبا، حتشوفه كل يوم بعيادتك بمرضى الدايابيتس. الافكت كانوا السمفاستاتين الليبيد نزلوا ال LDL، اللي عمل الكومبينيشن على اليمين they have significant reduction بالترايجليسرايدز، وبالتالي you were effective بتنزيل الترايجليسرايدز مع انهم ما كانوش عاليين كثير to start with. بس هذا translated into primary reduction بالايفنتس. اذا طلعت هنا على الشمال الكورونري هارت ديزيز ايفنتس وعلى اليمين التوتال كارديوفاسكولار ديزيز were reduced بس by adding fenofibrate on top of standard statin reducing triglycerides. اذا طلعت على needing microvascular problems retinopathy needing laser therapy progression microalbuminuria برضو كان improved. فaddressing الtriglyceride level regardless of the value تقريبا بالdiabetic patient كان effective in reducing retinopathy and nephropathy. هذا السمري تبع الفيلد ستدي. على شمالك الماكروفاسكولار، على يمينك المايكروفاسكولار، كلهم نزلوا ومعظمهم to significant p values. You have less composite endpoint, less cardiovascular death, cerebral vascular was reduced, الناس اللي اجوا انجانا were reduced. فرغم تنزيل ال LDL to similar levels بالستاتين adding الفينوفايبريت نزل، الامبيوتيشن was less, retinopathy was less، وبالتالي this is very encouraging to combine this early on. برضه بالشيء اللي حكيناه قبل شوي موضوع ال LDL، اذا طلعت على الشمال بنفس الدراسه او سب جروب اسمها السفاري طلعوا على السايز اوف LDL. فاخر كولوم على شمالك هو تركيبه ال LDL large medium small dense على البيز لاين التو كولومز. على اليمين هون شو صار بعد ما ضفت الفينوفايبريت مع السمفاستاتين. الاحمر كبر، الاحمر هو الميديوم سايز، بالتالي السمول سايز LDL صار اكثر ميديوم سايز، يعني كبرت ال LDL او منعت ال LDL الصغير ينتشر، وبالتالي you reduce the percentage of small dense LDL which is toxic atherogenic. وهي واحدة من التفسيرات انه why do adding fenofibrate تنزيل الترايجليسرايد مش بس بنزل الترايجليسرايد، نسبة السمول دنس LDL بتصير اقل، وبالتالي نسبة التوكسيسيتي بتصير less likely. My message from this presentation very simple. Okay, intensify statin حسب الجايد لاينز، push to the maximum dose، بس consider early combination therapy in diabetics تقريبا regardless of the triglyceride level، لأنه this will translate into reduction بالماكرو and microvascular events. Well, thank you for your attention.
Thank you very much, Dr. Iyas. It's my pleasure to welcome. It's my pleasure to welcome Dr. Suhail Hamoudi, who is a consultant interventional cardiologist and fellow of the American College of Cardiology. Dr. Suhail, the mic is yours.
Thank you. شكرا حكيم. شكرا محمود على الدعوة. مهد لي كثير أنا الدكتور إياس بالموضوع، وبجوز يكون هيك أسهل علي. Contemporary lipid lowering therapy, are we at the limits of LDL reduction and PCSK9 inhibition؟ بجوز هذا الموضوع شوية لسه لأنه غير مطروق، فمنشوف. It's still we know that cardiovascular disease still the main killer all over the world actually. If you look at those numbers, around 18 million per year, it is more than the cancer or more than the chronic lung disease. Let me show you few slides from history. يعني مثلا if you remember إيش اسمه miracle study done in year 2000 where people randomized patients after acute coronary syndrome to high intensity actually statin therapy, atorvastatin 80 milligram versus placebo. And what we got at 16 weeks, it was short run of the study, at 16 weeks we got 16% relative risk reduction, and people at that time said that the miracle study was not actually miraculous. And then after that came the proved study. We're trying to intensify lipid lowering therapy or statin therapy, and patients were randomized between 80 milligram atorvastatin and pravastatin 40 milligram, which was considered as weak statin. And in spite of more reduction of LDL, we got again 16% relative risk reduction of cardiovascular events and cardiovascular death, which was not that significant. And then came the improved. What about adding some other therapies to the high intensity or moderate intensity statin therapy, trying to get the events more and more less? And patients were randomized to statin versus statin plus ezetimibe. And in spite of more reduction of LDL, again, there was actually very small reduction of cardiovascular events in this study. Actually, if you look at those studies, this is the way we practice till now. We are prescribing 40 milligram of Lipitor or 20 milligram of Crestor at maximum and running the patients, and actually we are not following what is the LDL, what's the target, are we at the target, should we intensify the therapy, what are other medications that we can add to patients. So if you look at this diagram, you can see البار الثاني انه low intensity statin therapy و moderate intensity statin therapy اللي بالgray color لتحت, how many of the patients, and this is in year 2020, how many of the patients, what the percentage who are actually at the recommended target of LDL, and you can see in low moderate intensity it's around 13%, and with the high intensity it's around 20% of the patients, and 80% of the patients actually are out of the target. So have we reached the limits of LDL lowering? Maybe the answer immediately we can say no. Have we reached the limits of how to approach the PCSK9? يمكن zero actually practice we have till now. Have we reached the limits of cardiovascular outcomes? Of course not, because we are not at the limit of LDL and PCSK9 inhibition. What are the recommendations? You already went through that maybe during the first talks. In patients with very high risk, the recommended level is 55 and below. هي أسهل إشي كيف يتذكر who are at high risk, لأنه زي ما أنتم شايفين criteria of every risk group is so many. But any patients with proved atherosclerotic cardiovascular disease, with proved clinically or by imaging, is at very high risk. يعني هذول actually most of the patients that we see, or long-standing diabetes, or severe left end-stage renal failure, or with familial hypercholesterolemia, all those patients should be at the target, and the target is 55 and below. So if you look at the recommendations, there is some discrepancy between the ACC/AHA guidelines and the European. The European recommendation more aggressive, with LDL less than 55 in very high-risk group, while the American put it at 70 and less, although we are not reaching even 70 and less. What are the shifts that we have to make now? We have to shift from just the number, the LDL level, serum level, to the cumulative LDL exposure. What do we mean by the cumulative LDL exposure? It is the LDL level multiplies by the years during that period the patient has been with this level of LDL. So if multiply by that, you will get the cumulative effect of the LDL. This may explain why in all statin trials, by the way, we are not getting big results, because the maximum follow-up during the trials was maximum 5 years, and at 5 years we were getting 18, 16, 20% relative risk reduction and not more. So if we imagine a patient who lives with LDL 80, so at certain point at age 60, he will start to have increased risk of myocardial infarction, 1, 2, 3%, and above that. But if he was having LDL level of 125, his risk to start having myocardial infarction will come much earlier. بدل 60, he will start having the risk at age 40. And if he was having LDL at age LDL level of 200, he will start having the risk of myocardial infarction very early at maybe 20 years old. So this is what we were getting during the trials that we were doing. Just we saw patients at age 55, 60, and we gave them the statin therapy, and we look at the relative risk reduction, and it was most of the time very small, Why? The main reason, not because the intensity of the therapy was small or moderate, maybe because the period of time the patient was under treatment is very short period. So if you can imagine that we start treating the patient very early at age 20 and we switch this patient from LDL 125 to level 80, and you can see the big difference in risk reduction of this particular patient in his whole life. What did we learn from the statin trials? We learned, as Iyas said just now, that any reduction is good, that if we look at the primary prevention trials, if we can reach, in theory, level LDL 55 and below, we might reduce to the minimum the incidence of cardiovascular events. And if we look at the secondary prevention trials, we can see the same thing. And if we can reach the level of 30 and below, we might reach minimal incidence of cardiovascular events. We learned that any reduction of LDL is good, and the reduction of 1 millimole, which equals 40 milligram percent, will give us 22% relative risk reduction. That high intensity statin therapy is much better than moderate or low intensity statin therapy. And very important thing was noticed from the statin trials, that the benefit that we see during the first year was much less than the benefit that we can get during the following years, which confirms the fact that the longer the therapy will be better for the patients. And this slide is taken from the Jupiter, where they found that there is certain group inside the trial who reached the level of LDL 50 and below. And when you compare this group of patients to placebo, or to the patients who were with level of LDL above 50 and they did not reach the level 50, there was added significant reduction of events in this group. And this is the residual risk that Iyas was talking about. In spite of any statin therapy, any combination that you are giving, you will still have significant risk reduction, because most of the time the duration or the cumulative exposure to LDL is short in most of our patients. Are we doing a good job? Are we at the LDL reduction? هي مش المشكلة إنه to give therapy or not. How many of the patients are at the target of LDL reduction? اللي فوق, it is a registry done in North America, and we can see that 80% of the patients are not at the target. واللي تحت نفس الشيء 80% are not the target, and it is a European registry. This is the Da Vinci study. How many of the patients get the LDL level according to the 2019 recommendation? From the patients with cardiovascular disease, atherosclerotic cardiovascular disease, just 18%, and if you take all the group altogether, it's around 33%. So actually, we are treating, or we're getting just 20% of the patients to the target. What about the PCSK9? How can we add more therapy and to go beyond the statin therapy to reduce the LDL? This slide is the starting point of all those studies. As you can see, on the upper fill in blue, the distribution of the LDL in patients with normal PCSK9 function, without loss of function, and most of the people are having LDL between, as you can see, 100, 150. And if you look down for red bars, you can see that people with loss of function PCSK9, يعني الPCSK9 بيكون واطي, you can see that the LDL distribution in the serum, it goes below, most of the patients below 100. And it was seen in genetic studies, Mendelian studies, that there was significant reduction in those patients of the cardiovascular events. A few slides just to explain to you how it works, what's the PCSK9 and how it works. It all goes around the LDL receptor. So you can see that the LDL receptor, it catches the LDL اللي هي زي الكرة, and it takes the LDL inside the hepatocyte, and there will be degradation the LDL molecule, and the receptor will goes to the surface. It will resurface again and will catch more LDL inside, and it will degrade the LDL and will goes up to the surface, and you will have enough amount of the LDL receptors that takes the LDL from the serum. What happens when the PCSK9 is attached to the LDL? You can see that when it is attached and it is inside the cell, both the LDL molecule and the LDL receptor will be degraded. Both will be degraded. So we have a very small number of LDL receptors, and so many LDL molecule will be in the floating in the blood, and we could not reach a reduction of the LDL. If we can inhibit this molecule, the PCSK9, and prevent the PCSK9 to be attached to the LDL receptor, we can go to the first cycle with resurfacing of the LDL receptors to the hepatocyte and resuming their normal function. Maybe this gives one explanation why even in statin therapy, we are not getting, when we are doubling the dose, tripling the dose, we are not getting significant more and more reduction of the LDL, as you can see, because when the cholesterol is down, we got activation of SREBP activation, and with activation of this enzyme, we get activated the LDL receptor expression, and this will increase the amount of LDL receptor, which is very good because this will catch more LDL from the blood, but at the same time we increase the expression of the PCSK9 expression, and by increasing the molecule of PCSK9, this will attach to the molecule, and this will lead to the degradation of the LDL receptors. So maybe because of by increasing the dose of the statin and reducing the level of cholesterol inside the hepatocyte will lead by indirect way to the increased expression of the PCSK9, and this really not a good thing to do to our patients. Is there any trials that prove that by inhibition of the PCSK9 we can reach significant reduction of LDL and significant reduction of clinical events? Yes, this is how it works. You see different doses of PCSK9 inhibitor, evolocumab, and you can see by giving small dose, moderate dose, high dose, in blue down, يعني اللون الأزرق تحتاني, you can see there was significant stable level of PCSK9 and around 60% reduction of LDL. Is there any clinical data on that? Two major studies done on that. The Fourier trial looked at patients with chronic stable coronary artery disease with LDL around 90. They were given the PCSK9 inhibitor, and their LDL level was brought down to 30 milligram with around 60-70% actually reduction. But the median follow-up was not that long. It was around 2.2 years. And you can see there was 15% reduction of primary endpoints and 20% reduction of the secondary endpoints. The second major study, the Odyssey done in patients with acute coronary syndrome, with patients with level of LDL around 90, and it was brought with the PCSK9 inhibitor down to 30 and less, and there was significant reduction in events, and there was 20% relative risk reduction of all-cause mortality. Is there another way that we can inhibit the PCSK9 without giving the PCSK9 inhibitors? Yes, if we can inhibit the message coming from the nucleus, the PCSK9 mRNA, زي الvaccine يعني, because every protein has this message to go to inside the cytoplasm to get the production of this protein. If we can inhibit this protein, this message from the cell, we can block totally the production of PCSK9. And with siRNA, the inclisiran, the newly introduced PCSK9 inhibitor, when it is given, it inhibits, actually it takes the PCSK9 mRNA, it degrades this message, and there will be no production of the PCSK9 inhibitor. This is, and how often we should give this medication? It should be given actually not at the PCSK9 inhibitor twice weekly, every 2 weeks. This should be given just every 6 months, one injection for 6 months, and we can reach, as you can see, stable, significant 60% reduction of the LDL, and this is on top of the high-intensity statin therapy or high-intensity statin therapy with the combination of ezetimibe. Was خلصت 1 minute. Was there clinical event reduction in those trials? This is the Orion program, 9, 10, and 11. 9 done on patients with familial hypercholesterolemia, 10 on patients with ASCVD, and the last study, 11, done on patients with risk factor. And there was actually significant reduction of the LDL level, and there was significant reduction of clinical events. I will skip Padol just to show you how many of the patients we can reach with those inhibitors to the target. If you remember, on high-intensity statin therapy or on patients with high-intensity statin therapy and ezetimibe, we could reach just in 22% of the patients. Now we can do this on 70% of the patients. We can reach the level of reduction. Let me go back to this slide as I showed you. So by giving just what we are practicing, moderate high intensity statin therapy, most of our patients will be out of the target. So now we have actually to switch our thinking from statin therapy to lipid lowering therapy, from LDL serum level to LDL cumulative exposure, from statin therapy intensity to lipid lowering therapy intensity. And we have to switch our thinking from pleiotropic effect to Mother Nature doesn't care how we reduce actually the LDL, and from the lower the better to the lower and the longer the better. And thank you. شكرا تأخرت شوي.
Dr. Suhail, thank you. It's a very short question for you. Do they have, just one simple question, do they have really no side effects, these drugs?
في عندي كثير سلايدات على السايد effects. Actually, the only side effects it is at the local site of the injection. They divided it mild, moderate, severe side effects. Most of them were mild to moderate.
Thank you.
Okay, good afternoon, everybody. Thanks for the organizing.
Let me just introduce you, Dr.
Okay.
Islam. It's my honor to introduce Dr. Islam Abusido. He's a consultant cardiologist, American board in internal medicine and cardiovascular disease with years of experience in diagnostic and therapeutic cardiac catheterization. He's a fellow of the American College of Cardiology. His topic will be statin intolerance, the prevalence and management.
Okay, thanks, Dr. Ayman. Thanks for the organizing committee. Thanks, Dr. Mahmoud Izraq, inviting me to be with you tonight. I think the topic that I'm going to discuss, it's extremely important. This is the real challenge that we face on daily life, a practice actually facing our patients having atherosclerosis, dyslipidemia, coronary atherosclerosis. And I guess this is an important topic as well, starting from medical school, reaching to highest level of education. So we're going to go over the latest data that we gathered about statin intolerance, and we're going to cover the prevalence and the treatment of this topic. Now, as everybody knows, that cardiovascular disease is the leading cause actually of morbidity, mortality worldwide. And despite continuous improvement of medical treatment, diagnosis and risk factor control, it has been clearly demonstrated that statin therapy confers significantly mortality and morbidity benefit in both aspects of primary and secondary prevention, as shown with the previous slides from Dr. Suhail. Although the statins are among the most commonly prescribed medications, non-adherence and discontinuation of the statin therapy is actually an ongoing problem worldwide. And actually the most common cause of discontinuation of the statin therapy as we face on daily practice is statin-associated muscle symptoms. were other possible statin-related adverse effects that we might face as well: neurocognitive disorders, hepatotoxicity, hemorrhagic strokes, and renal toxicity as well. These conditions may lead, unfortunately, to discontinuation of the medicine, but causality actually has been confirmed only for statin-associated muscle symptoms, with a temporary also elevation of aminotransferase and the newly diagnosed diabetic patient. Now, how they define actually statin intolerance? The National Lipid Association has a wide definition, including any adverse effect relating to the quality of life and leading to the decision to decrease or to stop the use of an otherwise a beneficial drug like statin. The International Lipid Expert Panel, they define it as the statin intolerance as the inability to tolerate a dose of statin required to sufficiently reduce an individual cardiovascular risk. And the Canadian Consensus Working Group refers to an inability to tolerate 2 or more statins at any dose, or an inability to tolerate increasing or escalating the dose. Now, this is kind of a summary for risk factors actually that are associated with the statin-associated muscle symptom. Well, female gender, advanced age, in particular those above 75, we're facing a frail, actually elderly geriatric patient having decrease in the lean body mass and the reduction in the albumin levels and the decrease in the GFR. These contribute actually to such a problem. Abdominal obesity and metabolic syndrome as well. Those who had vitamin deficiency and those who consume alcohol, talking about over 30 grams per day in men and 20 grams per day in women, excessive physical activity, and not controlled hypothyroidism. Other problems contributing to statin-associated muscle symptoms are the chronic kidney disease, chronic liver disease, family history of statin intolerance, and personal history of intolerance to other statin and lipid-lowering agents, and the drugs actually that we prescribe on daily practice that actually affect the metabolism, that increasing the plasma level of the statins, and in particular, some of the SSRIs, verapamil calcium channel blockers, amiodarone, a famous medicine that we actually write it on daily practice as well. Now, this is the latest actually cohort that was just published 3 weeks ago in the European Heart Journal. We're talking about the prevalence of statin intolerance. This is a meta-analysis. And the key question was here, what is the overall prevalence of statin intolerance worldwide? And what are the main risk factors for statin intolerance? So this is an excellent actually meta-analysis that looked up for 176 trials involving almost 4 million people, talking about an overall prevalence of a statin intolerance of 9%. It's between 8 to 10. And they look up for all these risk factors showing here in this diagram, talking about race, whether Asian or black, they are more prone to have a statin intolerance, talking about obesity, hypothyroidism, uncontrolled diabetes, antiarrhythmic medication, alcohol consumption in excess, and over-endurance exercise as well, and those who got calcium channel blockers, those who had chronic problems like chronic liver disease, chronic kidney disease, depression, and talking about frailty, those who are elderly and female patients. So looking at this meta-analysis, the number of studies, as I just mentioned, 176 trial, and look at those randomized controlled trials. Once we talk about randomized controlled trials, we're talking about a very powerful trials. It's 112 trials involved in this meta-analysis, so you can appreciate that this meta-analysis is really strong one to tell you about those patients who had statin intolerance. And the overall prevalence on all the trials actually involved in this cohort or meta-analysis was 9%. and involving all the definitions that I just mentioned previously with a total sample size of 4 million people. And as you see here, the female contribute actually to those trials by 40%, and the mean age was really average or median age of 60 plus minus 8 years. Here, probably, it doesn't shine up the thing that I'm just like to show you. They focus actually on the major risk factors that contribute to the statin intolerance, whether age, elderly, female gender, and those black or African Americans or Asians, actually, they contribute to such a problem. Now, the key finding of this meta-analysis is that the overall prevalence was 9.1, and even lower using the international definition that I just mentioned. Female gender, hypothyroidism, high statin dose, advanced age, anti-arrhythmic medication, and obesity were the main factors that increase the risk of statin intolerance, with a take-home message that clinicians should use these results to encourage adherence to statin therapy in the patient that they treat. The author actually concluded that the study puts the prevalence of statin intolerance at 6 to 10%, meaning that statin intolerance actually is overestimated and overdiagnosed in most of the cases. It also means that around 93% of patients on statin therapy can be treated effectively with very good tolerability and without any safety issues. Now, talking about if we face it on our practice, what shall we do? How to manage statin intolerance? First, we have to confirm that the patient had statin intolerance. In a patient who's suspected to have statin intolerance, statin therapy should be discontinued and symptoms monitored over 2 weeks to see if they resolve. Patients should be asked about alcohol intake and nutraceutical medication, as they are potentially contributing to and confound muscle symptoms attributed to the statins. After 2 weeks, if symptoms have resolved, the same statin can be restarted at a lower dose, or an alternative statin should be considered. Strategies now for treating statin intolerance include using an alternative statin with a modifying dose and changing the diet and using other medications. Second thing, we have to try another statin. Pharmacological profiles can differ significantly among statins. We have to differentiate between lipophilic statins and hydrophilic statins. The lipophilic, they diffuse actually non-selectively into extrahepatic tissues, such as muscle, where the great example is the simvastatin is the most lipophilic statin and is the most associated with muscle symptoms. Hydrophilic statins actually are actively transported into the hepatocytes, and the examples are pravastatin and rosuvastatin, which are less associated with muscle symptoms. And changing from lipophilic to hydrophilic statin actually is a reasonable first-line alternative treatment strategy for patients experiencing myalgia. Next is to adjust the dose. Intermittent rather than daily dosing can also be considered for patients with statin-associated muscle symptoms. And for patients who have a history of severe myotoxicity and marked CK elevation should be considered. And I remember Dr. Steve Nason was one of the actually first people that pointed toward this methodology. Studies have found that intermittent dosing can achieve low-density lipoprotein reduction in about 20 to 60 or to 40%, although it impacts on cardiovascular outcome. We did not have yet any established impact on the cardiovascular outcome. There's a large single-center study of statin-intolerant patients that found a trend toward mortality benefit with intermittent dosing. A statin with a long half-life, such as rosuvastatin, may be a good choice actually for intermittent dosing. Now we have other modalities like non-statin drug therapy. Everybody is aware about ezetimibe, pembodoic acid, which is released by FDA in 2020, and the PCSK9 inhibitor that covered well by Dr. Hamoudeh. Now, what are the promising new agent? As mentioned previously, inclisiran is a promising one to lower the LDL. Evanicumab actually is a monoclonal antibody that blocks angiopoietin-like 3 protein that inhibits lipoprotein lipase and subsequently lower the LDL. And finally, we're going to cover the nutraceuticals. The nutraceuticals are natural food-derived substances that are generally well tolerated and provide health benefits, including the prevention or treatment of medical conditions. Two of the most widely studied in the cardiovascular medicine are the red yeast rice, which contains monoclonal K, the active ingredient of lovastatin and berberine. The lipid-lowering effects actually occur via multiple mechanisms, which inhibition of intestinal absorption of cholesterol, inhibition of cholesterol synthesis, and enhanced excretion of LDL. Nutraceuticals have been found to lower LDL. The red yeast rice was found to reduce LDL by 27% compared with the placebo. However, LDL reduction are modest compared to pharmacological treatment, and the long-term effect on the cardiovascular outcome with nutraceutical therapy has not been formally evaluated. Therefore, they should be only reserved for patients who are truly statin intolerant as adjunctive to non-statin pharmacologic therapy. Thanks for your attention.
Dr. Islam,
Questions?
just a simple question. So it's 9% intolerance worldwide?
Yes, sir. This is
In our
the latest.
practice here in our Arab world or in Jordan, I guess it's much more.
Okay.
I can feel that like everybody is coming back and said I have muscle pain. I can't stand this.
This is an excellent point that raised by our colleague Dr. Ghanma. هلا في trial قبل هذه بس I don't have the time to show it to you about موضوع nociceptive effect of those statins. كان في nice trial published recently actually last year اسمه Samson trial. وهذه اللي بنشوفه in practice. أنا سمعت من جاري إنه بس أخذها تكسر عظامه الدواء. فإحنا this is what we face in real practice, that what we hear from the others. هلا الشغلة الثانية اللي I should stress on إنه أغلب مرضانا يعني like United States حياخدوا الدواء اللي هو الجينيريك. هلا اللي الجينيريك اللي كتير available in the market unfortunately اللي هو I just pointed toward is the simvastatin وهو أشهر واحد medicine to cause actually myalgias and symptoms, to be honest with you. So I would raise the issue of nociceptive effect اللي بسمعه من أصحابي ومن جيراني. They compare in Samson أخذوا البلاسيبو وأخذوا statin ولو إنه النسبة يعني almost is very sky high that those who got the placebo because they took the pill, I start to have myalgia and cramps because he started to take the pill. It's cheap.
You know, simvastatin is just melting away. Yes.
That's for United States, amen, not for Jordan.
Has a lot.
Any questions? Thank you.
It's my pleasure to welcome Dr. Omar Abu Hijli, who is a senior consultant endocrinologist at the private sector. He is a fellow of the Royal College of Physicians. He will talk about the interesting topic, cardiorenal metabolic risk management in type 2 diabetes.
شكرا for the Cardiology Society and for Dr. Zreik for this organizing this meeting actually, which I found the attendance is perfect, in particular that we are still in our working hours on Thursday. And thank you for Boehringer for sponsoring this activity. My talk actually today about the cardiorenal metabolic risk management type 2 diabetes. And you know now diabetes can be considered as a metabolic disease long time ago, but because we have no ways to improve the cardiovascular outcome, this point was little bit ignored. But recently with the advent of the new medication which improved the cardiovascular outcome, the concentration and the emphasis on management diabetes and reducing the cardiovascular diseases is very important and vital during management of our type 2 diabetes. My agenda today is about diabetes burden SGL inhibitors and recent guidelines, because there is a lot of changes happening every year, even every 6 months. There is always an update about the guidelines because of the coming studies every now and then. And also at the end, I will mention a few studies about the Empagliflozin and the improvement of the cardiovascular outcome in type 2 diabetes. Just a recent figures about diabetes in the world. This is the IDF Atlas. This is released in September 21 about the burden of diabetes worldwide. And you can see here that in 2021, the prevalence worldwide is about 10.5%. That means about 530 million population of diabetic in the world. With the cost, if you look at the cost, is 966 billion a year. This is a very huge cost. The other thing that there's about 1 death every 5 seconds in the world, and the cumulative death is over the last year was about 6.5 million. There is still, this is also another problem, that these patients who are undiagnosed and constitute about 44%, about 240 millions, they are undiagnosed and they are developing every now and then a complication without knowing. There is about 80% of the population with type 2 diabetes worldwide are living in low and middle income countries, and this is also another problem, which means that the treatment and the care of diabetes will not be optimal in these countries. It's predicted that in 2030, the prevalence will rise to 11.3 with 643 millions. And in 2045, the prevalence also is going to increase to 12%. About 780 million people with diabetes will live you will find in 2045. If we look at our area here, the Middle East and North Africa, in the orange color, I will enlarge it just to see what's going to happen in our region. Last year, we have about 73 million type 2 diabetics in our region. This will rise to, in 2030, to 95 million, and in 2045, it will come to 136 with an increase of 87% increase in diabetes. So prepare yourself for this huge number of diabetic will come to your clinic every day. Now, the other burden of diabetes is not only the prevalence, it's not only the cost, it's not only the diagnosis, but also the comorbidities and mortality of diabetes. Diabetes in patients who have previous cardiovascular disease will lessen his lifespan by 12 years. About 2/3 of deaths in patients with diabetes is due to cardiovascular disease. The adult with diabetes has 2 to 5-fold increase risk of dying from cardiovascular disease, and the cardiologists here, they know what the means of diabetes, especially coronary artery disease, cerebrovascular disease, peripheral vascular disease, and heart failure. The other thing that 1/3 of people with type 2 diabetes, they have heart failure. So it's a very interconnected disease together. And the other way around, if you find a heart failure patient, a group heart failure patient, about 25 to 40% of them, they will have diabetes. So screen any patient in your clinic who is having heart failure being diabetic. Chronic kidney disease also is a very high prevalent in diabetics. It reaches about 20 to 40% with diabetes. The other thing really which is serious about the metabolic aspects of diabetes and the effect of other system is the 10-year mortality in type 2 diabetes with diabetic kidney disease, especially albuminuria and impaired GFR, is about 50%. This is really a very, very high levels of mortality and morbidity. Also, cardiorenal disease is the most common cardiovascular manifestation in type 2 diabetes. This is a study done in Europe. If you can see, the most prevalent diseases in diabetic patient is the cardiorenal disease in the form of heart failure and chronic kidney disease, followed by stroke, myocardial infarction, and peripheral arterial disease. It's the same figure as you can see in the screen. If we look at the first presentation of diabetic patient with cardiovascular disease, this is very important. You can see the most prevalent thing. The patients after about 5 years, they usually present either with peripheral vascular disease, heart failure, or myocardial infarction, stroke, or cardiovascular death. And the same look at the development of a chronic kidney disease in the form of albuminuria and renal impairment in 15 years. About 40% will have albuminuria and about 30% will have already impaired kidney function. So these three diseases are strongly correlated to each other and one perpetuates the other. And this is how the circle comes. If you look at the risk factors down for metabolic diseases, all of us, you know, it's obesity, diabetes, dyslipidemia, and hypertension, in addition, of course, to smoking and the lifestyle and the other components. And this leads to a multiple of pathophysiological disturbances at the level of the cellular level, at the molecular level, in the form of the oxidative stress, the inflammation, the endothelial dysfunction, the sympathetic overdrive, and also the fibrosis. And there is two circles. The outer circles about the cardiovascular disease started all these risk factors with the pathophysiological derangement of the tissues will lead to atherosclerosis, coronary artery disease, myocardial infarction and stroke, left ventricular modeling leading to heart failure, and of course cardiovascular death, while the inner circle determine how the development of the renal disease developed in type 2 diabetes with the presence of this risk factor in the form microalbuminuria, macroalbuminuria, then the derangement of EGFR, chronic kidney disease, end-stage disease, and cardiovascular death in most of the patients with chronic kidney disease. So when we are discussing diabetes, we have to discuss all these interrelated issues. So I think now we have to move to the recent guidelines published in January this year by the American Diabetes Association about the management of diabetes in general and also how to reduce the cardiovascular risk. Of course, now this is a new term coming to the guidelines. It started to be mentioned in the last 2 or 3 years, the quality of the life of diabetic patients, because they have a lot of comorbidities. You have to give the patient the chance to live a good quality of life. Of course, all of us knows what's the essential factors in treating diabetes and controlling the hyperglycemia. And also now, the new issue of glucose variability is very important in the guidelines, and that's why now there is certain chapter in all the guidelines how to do the continuous glucose monitoring to prevent glycemic variability and improve the cardiovascular outcome. Of course, we reduce the hypoglycemia, we have to watch the weight, prevent the microvascular complications, especially the retinopathy and the neuropathy, and also control the associated common risk factor like the hypertension and dyslipidemia. What comes and in details discussed in these guidelines is to improve the cardiovascular and renal outcomes. And this is actually slide summarize all the things you have to do as a doctor and for what you have to support the patient. Regarding the doctor, you have to understand the preference in the medication and the patient preferences. And very important to control the hyperglycemia is to control and avoid the therapeutic inertia, which is delaying the management while the patient is running a hyperglycemia. From the patient side, I think patient education is very important. It's equal to the medication you are thinking is very important. Education is very important. Was the hypoglycemia, was the meaning of dietary instruction, was the meaning of observing his blood glucose at home. And you have to think about smart goals with the patient. Smart, you have to, the goals, it should be specific to the patient. You can measure the achievement, and you can achieve that thing, and also it's relevant to the patient condition and comorbidities, and it's time bounded. This is very important. Your follow-up of the patient is not strict after 1 month or 1 week or 3 months. It depends on the glycemia and the hyperglycemia and whether it's controlled or not. Some patients, you may see them, you need to see them every 2 weeks. The other, you may have to see them every 3 or 6 months. And this is all the things you have in presenting the patient. You have to assess his characteristic. You have to share decision with the patient. You can't give him the medication without explaining what's the medication, how it acts, what's the cost, what's the side effects. You have to do that. At the end, you will agree on the management plan with the patient and start to implement it, and the patient will go home. At home, he has to be monitored and supported by other teams, dietitian, the family, the exercise. And also, you put a schedule for follow-up to have a comprehensive and holistic approach for the treatment of diabetes. Now, everybody is looking about that to consider a specific factor which impacts the choice of a treatment. This is that last thing you have to think about after assessing all this thing, and then you have to decide what kind of medication you have to give your patients. This is the guidelines. This is mentioned for hyperglycemia, but they classify the patient according to their risk factor. There is a few changes happen. This is the old statements about first-line therapy is metformin and atherosclerotic cardiovascular disease and indicators of high risk. There is a change in the wording in the new guidelines. As you notice here, the new one is 2022. First-line therapy depends on comorbidities. They don't mention any more metformin to start with. It depends on the patient comorbidities and with the other changes. Also, if you look at the second red bar, you will find that just if you have indicators of high risk, you have to start medication which improve the cardiovascular outcome, which is, of course, all of them, either use the Sglt inhibitors, the GLP-1 agonist. It depends whether you have cardiovascular disease or chronic disease or heart failure. And you should notice also the first word in the recommendation here in the new one, it's recommend. While last year it was to consider. So there is a difference between consider and recommend. Recommend, that means you have to give. Consider, you have to think about. So this is another important change we have. Here also they explain about the use of medications in patients who don't have high risk, who don't have previous cardiovascular disease, renal disease, or heart failure. Either, and you should classify your treatment according to the patient needs, whether he is prone to hypoglycemia, whether he has weight problem, or whether he has difficulty in purchasing the medication because of the cost. And they change the statements like that. Incorporate agents that provide adequate efficacy. Here you have to reach really in patients who don't have cardiovascular disease, you have to reach the target and the one which you can reach, even if it's less than 6.5, this is a good target to reach in these patients. Because, and also to consider the other factors in the patient. This is actually shared about how to reduce the cardiovascular disease by the American Diabetes Association and endorsed also by the American Heart Association. It's the same wording. You will find it in the American Heart Association because it's endorsed for the patients who have type 2 diabetes and they are more than 18 years of old with more or one of the following, whether he has atherosclerotic cardiovascular disease, heart failure, diabetic kidney disease, or high risk for these diseases. And you have to immediately address currently both columns here, you have to address at the same time. To optimize the treatment of the lifestyle, blood pressure, blood glucose, antiplatelets, and all the other risk factors. At the same time, to recommend either atherosclerotic GLP-1 agonist or SGLT inhibitors, and you have to discuss with the patient whether he will accept the medication or not and follow up. Of course, the stepwise approach for adding one therapy, second therapy, third therapy, or injectable, it depends on these two factors, the hyperglycemia and the control of HbA1c, and also the presence of other cardiovascular risk factor or previous diseases. Now, if we, at the end, we will discuss the effect of SGLT inhibitors and how they improve the cardiovascular outcome. I think most of you know that the SGLT inhibitors, they are working in an insulin independent manner. They induce diuresis, of course, they reduce the glucose elevation and natriuresis, and this leads to an intermediate effects, which you can see easily in the form of inhibition of the sodium-hydrogen exchange receptor, the bioenergetic of the myocardium. They are reducing the intracranial pressure in the kidney. They reduce the left ventricular mass stress, and also they reduce the inflammation and excessive stress, in addition to improving the hemodynamic of the heart by reducing the afterload and the preload, and also by elevating the hematocrit, which has some favorable effect in the cellular level. At the end of the day, they will improve the cardiovascular death and heart failure in the form of MACE. They also improve the kidney disease and deteriorate and prevent the deterioration of renal function. They have a good effect on the blood pressure, on the weight, and also reducing the HbA1c. If we, I think all of us knows the cardiovascular outcome of SG inhibitors, which are the Empagliflozin, the Canvas, and the Clear, and all of them showed a very good benefit on hospitalization for heart failure. Not all of them showed improvement in MACE or cardiovascular death, as you can see here, and the only one which reduced really the cardiovascular death in all the studies is the Empagliflozin outcome study. If we look at the kidney composite outcome, I think all of them, from the Embareg, the Canvas, the Declare, and the Vertis, all of them show a very good beneficial in protecting the kidney and reducing the decline of the glomerular filtration rate. And this is the end point, which is either you reach an end-stage renal disease, declining the recline, and the albuminuria. If we look particular about the empagliflozin, the most recent studies which published about it, especially in the heart failure, in the form embryo-reduced, embryo-preserved, and also the coming one, which will be, I think, released in June this year, about the EMBA kidney. This is on the right side, you will find the characteristic of the patient. They have a chronic heart failure. The left ventricular failure is less than 40 or more than 40. It depends whether it's reduced or preserved. And also they increase the ProBNP, the eGFR here. They use it in a patient who have just only GFR of more than 20. And I think this may change the guideline in the future that you can start this medication even with a patient with eGFR of more than less than 20. Also, they study the kidney disease progression. This is the embryo-reduced design. You are all of them cardiologists. I'm sure most of you have read this. It's a placebo-controlled trial in patients who are more than 18 years with heart failure, and the ejection fraction is less than 40, and the New York Heart Association classification between 2 and 4, even with or without diabetes. This is the study, and the primary endpoints was cardiovascular death or hospitalization for heart failure, and they assessed the secondary endpoint, the first and recurrent heart failure, also the eGFR slope decline and the change from baseline. And I think you can see clearly here that there is relative risk reduction of about 25% in cardiovascular death and heart failure. The absolute risk reduction is very good. It's about 5.2%, and the number needed to treat to prevent a hospitalization for heart failure is 19 patients. If we look here at the empagliflozin, it significantly improved the secondary outcome in the form of first and recurrent hospitalization for heart failure. And also, if you look at the annual decline of GFR, as you can see, it's improved much with the empagliflozin. If you look at both the effect on total, which is first and recurrent hospitalization.
We're running out of time, please.
Okay. You can see the same thing in either diabetics or non-diabetics. And at the end, I will close by the embryo preserved here, which is the empagliflozin in patients who have a preserved ejection fraction, which published last year. And the study endpoints is composite cardiovascular death or heart failure, and the secondary is the all heart failure events and the decline in GFR. You can nearly see the same figure with significant improvement in hospitalization for heart failure, and also it has been shown to also improve the decline in GFR. I think this is the summary of EMBEROR, and this is the result, as I said, and also regarding the adverse effects, as of the all Sglt inhibitor is the same effect, it's the same side effects in the form of genital and urinary tract infection, but you can improve them with the proper education of the patient. And thank you for your listening.
Thank you, Dr. Omar, for a very nice and interesting talk. We'll move to the second speaker because we are really in short of time. Our next speaker is Dr. Qais Al-Balbisi. He's an interventional cardiologist in Al-Abdali Hospital. Please, Dr. Qais. And University of Jordan. He just moved. I didn't know that.
Good afternoon everyone. مساء الخير. حبيت أشكركم جميعا وأشكر اللجنة المنظمة على inviting us to do this presentation. We're very enthusiastic about يعني حتى if we look at the subject of the summit, a cardiometabolic summit. This is something that we actually very much need in Jordan. بالأردن في كتير عندنا diabetes, في hypertension. It affects a lot of organ and needs a lot of teamwork or joint help. So this summit is right on the money. And thank you also, Boringer, for this opportunity to present an interesting subject which affects a lot of our patients. I'm going to try to cover a couple of things, outline, a little bit update on atrial fibrillation and some of the new concepts, the guideline. بعدين treatment of AFib, ABC pathway. بعدين we'll go over a certain part of the ABC pathway, which is C for comorbidities, which is the title of the lecture. All right, so update on heart failure. Now the concept of burden of AF. All of us are aware AF is a very, very common problem. And treating it is very important. It has 1 out of 3 have a lifetime risk of developing AF. It increases with age. Men are more prone. And you can see how much it involves all the global region. And now we're talking about how much AF affects the human economy, the human livelihood. It can cause death. It can cause stroke, which is extremely debilitating. It can cause left ventricular dysfunction, cognitive problems and dementia, and not to also to forget about depression and impaired quality of life. So it has an economic burden. It has a health burden. It's a very important subject. So if we treat it properly and in all aspects, we're really making a difference for our patient. Okay, so now I'm not going to bore you with classification of AFib. We're all are familiar of the different terminology. But what I need to cover is some vague terminologies, such as lone AF. Lone AF is really a terminology that creates more confusion. There's no such thing as lone AF. There's always some sort of an associated abnormality. So most of the guidelines tend to shy away from it. The second one is valvular AF. And of course, we know if you have a valvular AF, you're not supposed to use DOACs. You're supposed to use, the warfarin. However, the term is a little bit confusing because really the two conditions which are valvular AF, quote unquote, are moderate to severe mitral stenosis and mechanical prosthetic valve. So there's a lot of valvular disease which can come very much with AFib, and you still could treat with DOACs. So really we should shy away from the use of valvular AF and use the two exceptions, moderate to severe mitral stenosis and mechanical prosthetic valves, not even bioprosthetic valves. The third concept is chronic AF. Chronic AF, there's really no clear definition of what is chronic AF. You're better off using persistent or long-standing or permanent. Okay, so having said that, there's a new concept also, which is now that we have a lot of devices in our patients, we're tending to pick up some of what we call atrial high rates. And those patients might be actually at risk for developing strokes, and that's a big debilitating problem. So now there's the concept of subclinical AF, and there are ongoing trials to see whether we need to treat and anticoagulate such patients, because if so, then we need to be more vigilant about assessing the patients and picking up these diseases early on. Now, otherwise, we have a confirmed AF through either a telemetry strip, more than 30 seconds, or an EKG. And those are clinical AF, and we usually go through the usual definition. Now, as I said, if you have a device implanted and you can pick up the AF, that's great. But we also have some new tools, some new toys that can help us pick up AF early on, which was like AF screening, whether we're talking about pulse taking or some of the new watches, some of the new apps on phones that can pick up these episodes of irregular rhythm, atrial fibrillation. And you can see they're pretty sensitive, but the specificity is a little bit variable. And they have some risks, these devices, because they tend to maybe increase anxiety. They also can cause confusion or start the patient on unnecessary pathway of workup. The other concept that I want to come over is the 4S atrial fibrillation scheme, which is assessing the AFib not only through definitions. You want to assess the stroke risk through both CHA2DS2-VASc and HAS-BLED. You want to assess symptom severity. How sick is your patient? How much is the AFib affecting him really? Because that will affect your treatment method. Then severity of the AF burden. Now, if you notice here, I've used the AF burden, not burden of AF. Burden of AF is actually how much the AF will affect the human, his health, and the community. The AF burden is how much that individual actually has AF, how long he stays in AF, and his rate control. So it's a different concept. Substate severity which is the remodeling and what we call the atrial cardiomyopathy. That is the underlying cause of AF. All right, so we could assess the symptoms through the EHRA, the European Heart Rhythm Association symptom scale is a useful one. Atrial cardiomyopathy, I want to take a minute to talk about it. Imaging is very useful to assess and see what is the underlying mechanism. Why is this important? Because if I decide that I'm going to do rhythm control, these parameters are extremely important. So I want to maybe assess the morphology, the size, and it will tell me the success rate. But one of the most important assessments is to assess the risk of stroke. So, and the biggest two ways of doing it is the CHADS-VASc and the HAS-BLED. Now, for the sake of time, I'm gonna, because I know lunch is coming, I don't want to take too much of your time. I'm not gonna go into details here, but the higher your risk score, the higher likelihood of developing strokes. The trick is a lot of these risk factors are shared among both, which makes the decision tough. So, and this is what we're going to cover in the next point. However, now the treatment of is moving toward a team approach, same as valvular heart disease, same as CABG and coronary artery disease. It's a team approach that is going to handle the patients. All right, moving on. So, treating AF, which is the crux of our role in helping the patient. The ABC pathway, and this is mainly dependent on the European Society guidelines. The ACC don't put it in such terminology exactly. So A is for anticoagulation, B is for better symptom control, and C is our topic, the comorbidities associated with AF. Now, as far as anticoagulation, all right, so by ESC and by ACC, NOACs actually take a class 1 recommendation over vitamin K antagonists. The reason is their compliance rates are higher, better, and all the studies have shown that they actually help. There are certain scenarios where I would like to shy away from them, but overall, they're easier to use. Of course, there are different NOACs, including dabigatran, which is a direct thrombin inhibitor, apixaban, and rivaroxaban. Again, for the sake of time, I'm going to move forward. Now, what I do need to bring your attention towards is the different dosing. So there's the usual dosing of dabigatran, 150 twice daily. So same thing for the anti-10As, rivaroxaban and apixaban, 20 and 5. But there's also certain cases where you'd want to use the lower dose. And this is what we really need to focus on. When should we pick the lower dose? So for dabigatran, and it's 110 twice daily, if you have an age above 80, concomitant use of verapamil. This is something we tend to forget sometimes. And increased bleeding risk. Also, renal dysfunction, and we're talking about a renal dysfunction between, 30 to 50, not below 30. Below 30, it's not recommended to use dabigatran. Now, rivaroxaban and apixaban, rivaroxaban if you have, again, creatinine clearance decreased, apixaban if you have 2 out of these 3 criteria, which is again age above 80, serum creatinine high, and a body weight less than 60. And this, now, I always say in lectures, show me the evidence. And the trial is RELY for dabigatran, and it clearly showed across the spectrum of different complications and CV mortality that it actually decreases event rates and is helpful and protective for the patient. One thing I want to say here is, if you notice, the superior protection for dabigatran is definitely, and this is the only one, for ischemic stroke with 25% relative risk reduction. Of course, as far as decrease in hemorrhagic stroke, it goes across the board. But so you provide a little bit stronger protection against stroke. All right, again, I'm going to move forward. All right, now, one last thing about the assessment. If I do have a lot of bleeding risk factors, being more than 3 risk factors, has bled 3 or plus, I would probably use the lower dosing. All right, now B for better control, you have the rate control and the rhythm control. That's a whole new chapter and lecture, so I cannot cover it, and it's not the goal of this lecture. We'll move to our main event, which is the C for comorbidities. Okay, so we talked about the burden of AF, which is basically a lot of risk factors involved that cause AF, and in the same way, a lot of the patients who have AF have other diseases, such as diabetes, heart failure, and chronic kidney disease. And they are all interconnected. Some of them are genetics. You know, you're born a male, you're gonna age anyways, you can't control that. However, there are certain factors that we could control, especially the risk factors and the modifiable risk factors. A few things that I do wanna bring your attention towards is like inflammatory diseases. You know, SLE, rheumatoid arthritis, can also worsen the condition and cause further issues. Smoking, which is a big, big problem in Jordan, and we really do need to work all collectively as a physician body, whether it's endocrinology, cardiology, surgeons, we have to decrease the number of smoking percentage in Jordan. Okay, now, the other risk factors. So, and this is the part where we tend to sometimes forget or turn a blind eye to. So we're all good in rate control, rhythm control, and making sure the patient is on anticoagulation. But it's very important to make sure that his blood pressure is controlled, because high blood pressure, increased LVEDP, increased left ventricular filling pressure, stretch the atria, worsens the AFib. Glycemic control, and we just talked about the use and trying to control blood sugars. Obesity. Weight reduction is actually now a class 1 recommendation for treatment of AF. Smoking, we just mentioned, hyperlipidemia, which will affect in many ways. Alcohol can be a problem also. Sleep apnea and the need for BiPAP or CPAP. Extremely important, a highly important point that we tend to forget and underdiagnosed. And in addition, of course, physical inactivity. So these points we actually have to go over in every patient who has AFib, make sure that we're controlling this C factor. Okay, other diseases that might come in and tend to adjust our management. First one, I'm gonna cover coronary artery disease. And of one of the interesting trials is re-dual PCI. In this trial, what they did is they looked at patients who needed triple therapy. In a sense, these are patients who had coronary artery disease, had stents. They needed to have antiplatelet therapy in addition to anticoagulation for AFib. So most of the antiplatelet therapy was Plavix, clopidogrel, which is 88%. Some of them were ticagrelor. The rest were randomized to triple therapy with warfarin or triple therapy with dabigatran, high dose, 150, triple therapy with dabigatran, dual therapy dabigatran, 110. So triple, dual. And if you can see, if you look at the primary endpoint with the bleeding events, the dabigatran 110 and dabigatran 150, both actually did better and less bleeding. Now, if you look at the thromboembolic events and stent thrombosis, the dabigatran was non-inferior, or the dual therapy was non-inferior. Now, having said that, this trial was not geared specifically for in-stent thrombosis, but the thromboembolic events were not inferior. So this is where the guidelines came that you don't really need a long duration of triple therapy. And Europe is usually doing a week. Unless you have a higher risk patient, they do a month of triple after stent, and then they continue with dual. However, the states, they're leaning towards more of a 1 month, and then they switch to the dual. Okay, and again, I want to bring up your attention. It's class 1 to use a NOAC for post-stenting. So not Coumadin, NOAC. And we just went over how the dabigatran 150 is even safe to be used. All right, how about AF with heart failure? Again, it does work. It doesn't have a higher risk of complications, so it is safe. Now, CKD, we touched a little bit on top of on that subject. CKD, again, if you're talking about mild to moderate CKD, you can use DOACs easily. Now, if it is less than 15, don't use a DOAC. If it is in between, I would feel reluctant. Now, the States does give a FDA approval to the
2
75 dabigatran. I'm almost done. Thank you. 75 milligrams, but and in Europe, they actually recommend not to use it. Okay. And this is reflected on the guidelines. Okay. So last thing is AF and active bleeding. And we have that frequently. We either have an emergency surgery or a stroke that we need thrombolysis, or a surgery that, or a actually patient actively bleeding from the GI. If you have an antidote that is specific, it's a godsend. And that's exactly what we have with idrasazumab. Idrasazumab is a specific antidote. It's a human antibody, and it blocks it. It does not increase the procoagulant effect, and it's easily given in 5 grams in 2 doses. And you could actually start anticoagulation soon after. So in summary, we should have a structured team approach towards AFib. We should never forget there's a ABC pathway. NOACs are safe as a first-line therapy. And ultimately, if we get into a tight corner and we need a reversal agent, there is idrasazumab, which is available in Jordan. And thank you very much.
Thank you, Dr. Qais. Any questions for Dr. Qais?
I have a question. Dr. Qais, your AFib patient comes to you with a STEMI. What would you send him home on? What's your regimen?
So, AFib patient comes in for a STEMI, and then how to send them home. All right, so first of all, what I will do is, of course, not all animals are created equal. It depends on what kind of STEMI, how big and how long the stent is, whether I had good, results afterwards, was it complicated with no reflow or not, was there a lot of clot burden or not, and different things. But let's say it's a straightforward, run-of-the-mill STEMI, opened, good blood flow, everything's good. So what I usually will do is I will do aspirin, clopidogrel, okay, and a DOAC, all right, and then for a month, and then I will DC the aspirin, keep the clopidogrel and the DOAC for, of course, if the presentation is acute coronary syndrome, I'll keep it for a year. If it was stable angina, I could technically stop it, and it's again, straightforward, not the bifurcation stent or whatever, 6 months. And third generation stent, not a older generation stent.
I don't know if you can hear me. I know this is like puzzling for a lot of interventionalists. Like if your patient does have a valve or he has a fib, and you really, we heard the lecture about the ticagrel, and we don't want to take the benefit of ticagrel from those STEMI patients.
Yes.
That's why,
Okay, thank you for your question. Now, if I have a patient, as I said, who is not run-of-the-mill, so if it's a higher risk, and I really want ticagrelor on board, then I'll use it, and I'll probably use dabigatran because of the trial that I just showed, redual PCI, because there was a percentage, it wasn't a high percentage, but there was a percentage of patients on ticagrelor in that trial, and they did not have a signal of harm. So you could use it. And probably I'll use it at a lower dose. I will use it at the 110 rather than the higher dose. But that's for a higher risk patient. Yeah.
Thank you.
Any other questions?
Thank you, Dr. Qais. We can have questions for our distinguished previous speakers. Any questions for the previous presentations?
I have a question for Dr. Omar. Would you use the empagliflozins for pre-diabetic patients? Would you use the Sglt for pre-diabetic patients?
It's not licensed for this purpose, but there is in the studies who have been used in patients with heart failure without being diabetic, but they have pre-diabetes. It shows really delaying the development of diabetes and may reverse the patient to normal, but it's not indicated to use it to treatment of pre-diabetes.
Any other question? Otherwise, we end this session and
Can
we'll go to
I just
lunch.
want to, I mean, I know Dr. Iyas mentioned this about the small, dense particles. I mean, a lot of people are saying, you know, 50% of people come with a heart attack, they have normal cholesterol. Maybe there is something wrong with the test. We're using an 80-year-old lipid profile test. Now, they are introducing a new concept. You know, when you look at the lipid profile, you're looking at the number, the quantity of your LDL. But the test does not give us any idea about the quality of the LDL. So now, a lot of testing, we're doing an MRI on a blood sample, and we are differentiating the LDL, whether it's small, dense particle or large particle. We like to think of the large buoyant particle as less malignant than the small dense one. And the problem with the small dense ones is that even the receptor, because they are oxidized and they are kind of squashed, that the receptor, the LDL receptor, doesn't even clean those kind of cholesterol particles. So the thinking is sometimes your number might look good, but the quality of your cholesterol is bad. So maybe we need to go further in testing to test the quality of your cholesterol plus the quantity of your cholesterol. What's your thought on that?
I totally agree with the reason LDL states that primary target is simple. الناس متعودين على انه LDL is simple to measure موجود بكل مكان. بس if you look at LDL subtypes من LDL 1 بعرفش شو يوصلوا على LDL 7 ولا 8 كل واحد مختلف يعني هو قبيلة كامل ال LDL بس لأنه it's simple it's easy to use for everybody including internists to other subspecialists بضل موجود بس أنت if you have an advanced way of saying this patient has LDL 1 أكتر من LDL 6 he needs to have like a specific enhancement لل statin مهم جدا. something else احنا ما نطلعش عليه برضه السي ار بي مرات في مرضى بتلاقي ال LDL تبعهم اوكي بس السي ار بي بعده عالي وفي اكثر من دراسه حكت برضه هذا simple target if your CRP stays high معناها you still at risk. فالسبتايز اوف LDL مهمه السي ار بي مهم ويمكن برضه انا simple target ارجو بعد محاضره اليوم يصير الناس يستعملوه اكثر هو الترايجليسرايدز. كثير احنا بنشوف دايابيتكس عندهم ترايجليسرايدز 200 و250 وبضلوا مثلا يحكوا لهم خلص ضبط السكري بينزلوا الترايجليسرايدز. الفيلد والاكورد شود كليرلي انه this is a simple target to hit وادريسنج بالفينوفايبريت. حتى if this is the poor man's way of switching السمول dense LDL للارجر 1 بيكون احسن لانه بصراحه المختبرات اظنش يكون عندهم هلا it's not easy او it's not cheap انك تعمل LDL subtypes وبالتالي مش حيصير براكتيكال بكثير محلات. احنا we're stuck with LDL بس على الاقل بنحسن if you look at the CRP if you look at the triglycerides وصرنا more aggressive in adding fibrates عشان نحسن نوعية ال LDL.
Yeah, I mean, a lot of thinking is that triglycerides will convert to IDL, then to small density LDL. And it's worth mentioning that it's been said that one of the major sources of small dense malignant LDL is sugar. We keep ignoring the sugar. I think, you know, even when we put patients on low saturated fatty acids, the small dense particle number did not go down. What went down was the large buoyant particles. So an easy way of bringing your cholesterol or bad cholesterol down is really cutting down on the sugar and the carbs.
Yes.
Okay, thank you very much.
الغداء